Sometimes I think as doctors and practitioners, we are quite sterile, right? You follow certain rules, at the last moment it has to be cleaned up, remove tubes, put into a side room and all that. But for the relatives, your last remembrance of this is actually a very cold moment, which is not a nice memory. Why not give them that just 10, 15 minutes to be with the patient, even though we know he's not responding? Memory is actually very important. If you and I were the relatives, I want that memory as well, you see. I think sometimes we need to move away from a sterile environment. Like the sterile environment is for health, for best results, but there is a moment when some of these rules, I think, need a human touch to it. To be able to think and feel, you need to be comfortable with yourself. You need to have enough space for yourself as well. Burnout is about engagement, or I should say about the lack of engagement. After a while, when you are very emotionally involved all the time with your patients or even with the people around you, you start to protect yourself and your personal well-being by creating a wall around yourself. Like it's a natural protection. And once that happens, you can't engage, right? You really can't engage outwards anymore. And that reflects because the way you treat people becomes quite a disengaged feeling. So in fact, these days we try and talk about mindfulness, about some of these small techniques about taking care of yourself, right? It's just a few moments, take a few deep breaths. As an anesthetist, even when we were training, we do practice, and I do try and tell my juniors, taking 3 deep breaths is a good thing, because our main armamentarium is drugs. And once you give the drug, you can't take it back, right? And sometimes you react too fast. Maybe when you really want to give the drug, you think you really need to give the drug. Okay, take 3 breaths, okay? Nothing is going to happen in that 3 breaths, but it allows you to focus your mind on, do I really want to give this drug, right? It just gives you those few moments. But spending a few moments with yourself, a few deep breaths, just 1, 2 minutes with yourself, I think makes a world of a difference. My practice, which is anesthesia, and we run the ICU as well. Death is quite I wouldn't say common, but it wouldn't be a rare occurrence either. But I would say that certainly the experience in running the ICU and looking after sick patients, the experience does bring in certain things which maybe changes your attitude. I think maybe when you're a little bit younger, you sort of see death as a disease process. I mean, when someone is sick, at some stage, it seems, well, a natural thing that happens, right? But I think as I went along, I realized that death is not just about a natural disease progression. It is about your own views, the person's expectations, and also about the people around, right? It is about how the people around get, in a sense, closure. What do they experience in this very precious moment of their own lives as well? In surgery, when you come in for surgery, of course, the hope of the patient and the relatives is that things will be fine and you'll be cured, right? But in some circumstances, perfectly successful surgery doesn't mean that the patient will survive. And that's when, things get a little bit messy, because from the surgeon's point of view, everything is wonderful. They tell the relatives, oh, everything is great, it went perfectly as planned, right? And then as an intensivist, we come out and we sort of say, but actually the patient's not doing well, right? It can be a really difficult conversation for the relatives to understand what you're trying to say. But when you look at it, you can also understand why the surgeons sort of say, well, everything went well, it went according to plan, because it did. And from a technical perspective, from a personal mission kind of perspective, it is true, everything went well, everything went according to plan. But what else didn't quite go right? Because the total human being is different. You have to put everything together, right? And something else might not quite have fallen into plan, even though you planned it well. And this is something which I think sometimes patients do feel as well, because they develop a relationship with what you call your primary physician, especially, for example, an oncologist. It's a very long journey, right? Sometimes at the end of maybe a few rounds, when truly the oncologist sort of feels, okay, we have tried everything and it's not going to work, right? And it's time to talk about palliation and all that. Sometimes their feeling is that, okay, palliation, I'm going to refer you to somebody else who's expert in the field, right? The patient might actually feel that this sense of abandonment, the person I'm closest to has now, well, sort of passed me on to somebody else. And in their perspective, sometimes they feel that, they are no longer interested in me as a patient. But from the oncologist's point of view, it's not like that. You see, from the doctor's point of view, I've done my very best. I'm now passing you on to someone who is the very best in this next stage of the journey. And to them, I should now be focusing on another patient that I could be doing my best and I could be contributing my expertise, right? But I think sometimes we just have to be careful and be sensitive to this sense of abandonment from that the patient may feel when at this stage of treatment. As an anaesthetist, sometimes I'm definitely not the primary physician, but if the patient clicks with me, I would of course feel that you do want to keep in touch and journey with your patient. I guess it is true that sometimes prolonging life is an easier discussion topic, and because many of us are transactional. The patient needs this, we plan this, and then and we execute. So that is actually in our training, in our capability, quite expert field, you see. While discussing that is actually a very, very long discussion, right? I do remember a patient where the relatives were very engaged. In fact, I think the family support was superb, right? So I was asked to see the patient for suitability of a procedure, right? And when I went to see the patient, actually all the talking was done by the relatives, like, who sort of said, oh, they said we can do this and you can do this and this is the outcome and so on and so forth. I said, okay, very well informed. And after like a 15-minute, I sort of said, do you mind if I, speak to the patient, right? And they said, yeah, please. And then, I sort of asked the patient, do you mind if I speak to you, and would you like your relatives to be here? Would you like to have a private conversation? And said, no, it's fine. They are very supportive. It's fine. So we had a conversation. I sort of asked her, you heard the plan. What are your thoughts? And she actually said, I've been through quite a bit. Everybody's tried their best. I know all of you want the best for me. But actually, if you ask me, I actually don't want, whatever that y'all are planning now. I was actually a little bit shocked because I was like, okay. And I just stopped the conversation at that point, and I was expecting to be thrown out of the room, right? Because the relatives obviously have spent quite a bit of time thinking, planning, and maybe trying to convince her. So I just sort of said, well, I just stopped the conversation basically, right? And I think the relatives were also quite shocked. Actually, one of the relatives, it happens to be in a medical professional as well, right? And the person actually called me and said, frankly, we thought that we were doing the best for our loved one. But that occasion was actually the first time when they've actually heard what she wished and what she wanted. The family has now had another conversation, and she is part of the conversation, and we've decided that we'll go with her wishes, right? And in fact, one of the things he said was, maybe in all this planning, it was more about us than about about her. When my mother passed on, it was a similar experience, right? Right at the end, when we had all decided that it would not be an extreme intervention kind of situation. Even at the last moment, it is instinctive for the nurses to rush in, the doctors to rush in and bring resuscitation equipment and all that. And I had just kept reminding them, look, the decision was that we have done everything, and this is not the time when we want to go any further. So these are what I call very important moments. Palliative care, in a sense, is well, how should I put it? It's new, but it's not new. I mean, it's been around, but I think maybe the prominence and the recognition has not been as clear as it is now. And I think we all acknowledge that there is a major role for palliative care. The comfort of the end stage is actually quite important. So a few days later, I went back to see the family again, just to make sure, right, that the decision still holds. You see, and they agreed, right? They agreed. Look, this is what she wants, and maybe if you could help us, keep her comfortable, make sure that she's well, she's comfortable, and so that we can go home. And she went home and she passed on like a couple of weeks later. How I actually knew was because they actually put in an acknowledgement in the obituary. And in the tea room, when my colleagues looked at it and sort of said, "Wow, what great surgery did you do for this patient until they actually acknowledged." And then I sort of said, "Well, actually I cancelled it, right?" And everybody was like, "Huh?" But the truth is that it took, I think, a lot more effort, a lot more time and sitting with them and what I call journeying with the patient. Then if we had just proceeded, if we had just proceeded, it would have been like 2 hours and then it would be done. Okay, I've done my job, I move on, right? So that's why it is a easier conversation sometimes. Maybe when we're a little bit younger and when we practice in what I would call state of the art, right? When you sort of develop something new, a new technique and all that, then certainly there's sometimes this sense of failure when things don't go well, and after all the effort, right, it just doesn't go well. So in the back of your mind, you're thinking, well, before you even start your new project or your new treatment, right, it's almost like the end of your career. It sort of taught me that sometimes there is a place and a moment for these things. You have to move on, right? There are greater things and there are more things you can do. Like, you cannot be stuck in that moment and then nothing else happens. But of course, it does help when people around are understanding, especially the parents or the loved ones, right? That really does help, because otherwise you sort of really feel that people are holding you responsible for what they consider a poor outcome. But I think in all this, it's actually about communication, right? About the relationship, about keeping in connection with the patient and the people around, right? How you have explained it, how you have not just promise results, but you listen and you feel with them what they really want, what they have in their minds and in their hearts as well. Frankly, in the journey, it's not about just technical ability, just what's in your mind, but it's also what's in your heart, and coming to that compromise, right? Not everything can be the way that you want it to be, right? Not everything is in your control or mine. Right. Yeah. And I guess sometimes I worry that we go the other extreme as well, because yes, we now teach in a more concerted manner in school about the conversations around life and death, about expectations. But sometimes I worry that the other extreme happens, like that for the younger doctors, it becomes a very transactional conversation, right? because it becomes like, this is what we can do, and up to here, that's it lah. There's nothing else that we can do. And then you let go too fast and too easily, right? It's about feeling with the patient and with the relatives, which I think no amount of teaching can teach you that, right? You can teach knowledge, you can teach things for you to be prepared, for you to expect when someone says this, maybe the next nice sentence would be to say this. But the next sentence, you really can't prescribe, right? I mean, you can't have a script. If, when a patient says this, you say this. When a patient says this, you say this. You can't. Beyond, let's say, the first one or two lines is your own connection, right, with a person. Sometimes you connect and sometimes you don't, right? That's human relationships, right? I remember when I was in the States working, we had to attend this compulsory course or lecture on sexual harassment. I was like, huh? Okay, right. Singaporeans have never heard of it in those days. Of course, now it's come up to the front, right? On reflection, after I came back, I realized that actually in Singapore, as a female, you get very, very equal opportunities, and to a very great extent. Surprisingly, in healthcare, actually, if you look at the total workforce, it's actually predominantly females, right? The nurses and all that are predominantly females. Even medical school now is almost 50-50, okay? My time, yes, it was much fewer females. It's just that in a senior and a leadership position, perhaps there are fewer females in that kind of level. But I would say, in a great extent, it's not about gender. It's about what you bring to the table, what discussion points, what viewpoints are you able to, see the bigger picture and yet relate it to the last person on the ground. Amazingly, there's a study done about 8-10 years ago, and they looked at committees. Okay, they looked at individual ability of committee members, and they looked at the total ability of the committee. And what they found is, when you start adding women, the total performance of the committee improved. Okay, quite interesting. I never knew that, it's a study and it's published. Of course, my question to them was, you didn't finish the study when the whole committee becomes women, right? I don't know whether it's the mix that makes the performance better. But apparently, it is the women bring in a different perspective to reading body language, allowing other people's conversation to come in, very quickly reading in a room who doesn't agree, how to get that person to agree, and all these things, which I think to some extent it is true. It is true. Our communication styles are probably quite different. We look at nuances more than just what is said, right? Maybe what is not said is more important than what is said, right? So I think these are just things that we bring into what I call a group decision. From the building hospital perspective, I thought, the main thing I can say is leadership is not about leading like that. It's actually about bringing people together. I think one of the things which is very difficult during COVID is because we actually didn't allow people coming in. And if I remember, looking back at SARS as well, when our own colleagues die from at that point in time, it's a very rushed ending. There's nothing, right? It's almost an immediate cremation kind of thing. And I think that actually does affect the healthcare workers as not just the relatives. I do remember in Sengkang site when we had one of our first deaths in COVID, right? The wife was also a COVID positive patient who was actually out in one of the facilities. And I told them, look, whatever it is, like, we will try our best to get the wife to come in. Even if it's not to the bedside, at least you are at the door for those final moments. I mean, of course, it's not easy to arrange because, that was the start of COVID when everybody's quite scared, and then all the transport and all these things, and then we had to cordon off security, dedicated routes, and all these arrangements, right? But I realized it made a lot of difference for my own staff, right? People were sort of feeling that there is, in Chinese, you say 有人情味啦, right? At least what you see as management and all that are willing to take the extra step, even for a patient. For that kind of thing, the staff do get affected as well, right? What I think COVID really has impacted healthcare workers is not really just around the death, it's around the many, many things that you can't do, right? The 1,001 protocols, and to some extent, taking the brunt of relatives' frustration because they too can't see their loved ones. Also, you have to remember that the healthcare workers, some of them are not Singaporeans. They too have not seen their loved ones. And I know of quite a few who didn't make it back when their own close relatives passed on, right? And that really takes a very heavy weight on you, right? Here you are taking care of other people, but when it's your own loved one, you couldn't make it back. You couldn't make it back because you have to isolate one side, isolate the other side, by which time it is too late, right? And it's something that you live with for a long time. Of course, accepted as a situation of the times, but all these things I think adds on, and I think those are actually the things that take a toll on people. Somebody once told me, if I have a mission, I send 100,000 troops, and then, I know that I have to sacrifice 100, I will still go for it. It will be a successful mission. And I said, well, if you talk to the doctors, we lose no man, right? N is equal to 1. We try our best, in the ICU, it's so difficult to let go. I mean, we talked about the conversation around just do, right? Never talk about the chances of it not working. So doctors are N equals to 1. And then when you start talking about patient safety, governance, I think when I first started almost 20 years ago, the response I get when I sort of go up to somebody and say, hey, there's this thing that we should do for patient safety. My senior colleagues will look at me and say, I've been practicing for the last 30 years, and my results are very good, What are you trying to tell me, that I'm not safe? There's always a tension between the person on the ground and what they call 政府, the government. You can't have governance that is 100% works for every situation, right? It's always 99%, sometimes we say 80-20, There's always a tension. I think that there's this balance where, being on the ground and practicing as a physician, you know what works and what really doesn't work. Why I, in a sense, had an interest in doing this area of work was, after a while, you come to the realization that when N is equal to 1, you can only do good for one person. But from all these ones that you learn, if you can get the system right, it could actually benefit a lot more people, right? It can be a bit painful because there are rules to follow, but you could benefit more people than just the one patient who is your patient. What you have learned from your one patient that you translate to your next patient, maybe someone else could have learned that without having to go through the same pain that you went through. If the system can safeguard, have some boundaries that people can follow, maybe more people can benefit from this, right? So that's why I sort of thought, much as it's a pain, right? It is a pain because you end up having to talk to your colleagues, convince them that it's a good thing, what can we do that will work and all that. Actually, it is a very interesting incident. All right. So one day I came to clear my pigeonhole, and out of that thick, there was this book which occupied my pigeonhole on one of these audit processes. Okay, from US basically, and it had like something like 13 chapters. Okay, from clinical practice to safeguarding your pharmacy to facilities to fire to everything else. Okay, to be honest with you, I took one look at it and I went, what in the world? And I popped it into the bin. Okay. Like 2 hours later, I sort of felt a bit guilty about, throwing this whole stack of paper into the bin. I went back to pick it up and was going to look for a recycle bin, lah, right? And so I left it in my pigeonhole, waiting for a recycle bin to appear. In those days, you don't get a lot of recycle bins. Like you literally have to make a lot of effort to go and find them. And then somebody called me, and this lady sort of said, "Hi, did you see that book? Did you have a chance to read it?" And I was like, "Ooh, what book?" Right? Try not to tell her that it's actually in a bin. And she sort of said, yeah, can you just read one chapter? Pick any chapter, maybe the chapter on patient care. So I actually read the chapter on patient care, and I must say, I thought, hey, actually it makes a lot of sense, right? I think that I practice very good medicine. I practice very professionally, and I practice, at the top of my license, literally. But this chapter actually had a lot of sensible things that maybe we, even as doctors and nurses and people in the system, don't see, right? So that was what got me a little bit interested. And then, of course, after that, we had to get 13 people each, to read one chapter, come together. And it took us another maybe 2 years. And this was actually our first JCI accreditation process, right? Which, well, painful. And now we are evolving to something else. But that was a journey, that was a start. And after that, it became patient safety and governance as such, right? And this girl, she was actually a nurse administrator. Her name is Gyok Ing. She's still around. She's still in the system, right? So actually, that's how it started. My interest in patient safety. Right ethos, right passion, right agenda. If the people have the same thinking, it's actually not difficult. So I think from a leadership point of view, it's I guess first and foremost, how do you lead yourself? Your own personal passion and what you see you want done. But doing something on a wider scale, on a more systemic perspective, and contributing to what everybody calls the dark side, which is admin, can have long-lasting effect, which our one-to-one patient relationship is a complement of, you see. So I think if I had to say anything for the younger people, I think is to be prepared, right, to step up to what has traditionally been called the dark side. I think more and more people are willing. But put it into your mind that it's not a bad thing, right? On the other hand, if you do decide that you want to do it, then I would say think very clearly about what your agenda is. What do you think you want to do when you step up, right? Is it about your personal progression, your personal career, which I'm not saying is wrong, okay? Or is it about doing common good, okay? Improving the system, making it better for your colleagues, making it better for other patients and for the healthcare system. Because I think no matter what, all of us have tried to do what we can do in the system. We have done very well as a country and as a healthcare system. But if we keep going down the same route of doing things the old way that we do, you know that we'll run out of manpower. The whole community is aging. We'll run out of human resource. the same thing that we have always been doing for younger population is really not going to work for an aging population. How do we re-engage this conversation? How do we do, in a sense, a mindset change, go out to the population to maybe teach and I won't say teach, but gain awareness of what is the population's responsibility in your own care. I think if I look back in the past, my patients will say, "Oh yeah, doctor, you're the expert, like, you know what to do, you just decide." Nowadays, it's not like that. And honestly, patients do have to take ownership of their management as well, right? And all these things require people to come up to the next level, which is not just me and you, one, n is equal to one, is to come up to the next level to see it in a much broader perspective. So I would say for younger people, if you're thinking of stepping up and going into leadership position, open your mind, right? And think about what you really want to do. I think that's very important. Um, think about changing the whole system in people's mindset. You have to remember today, healthcare is no longer about just a doctor. If you think about it, we have so much support, right? The nurses, the admin, the things that get bought, the equipment that runs like a clock, without you having to worry about it. So all these people need engagement. It's not just the frontliner, it's everybody. And you have to be that person who can, in a sense, bring people together so that people enjoy working here, right? The guy who's a security guy also sees, I'm contributing to the care of this patient. The engineer who is doing your IT system and your aircon sees that, hey, my job is very important because without me, you can't do the operation. Or without me, how do they contribute to the patient? So I think these are very important things that the younger doctors do need to be aware of. Like, it's not just about you, it's about everybody. How do you bring everybody on board? Otherwise, you can't do a good job, right? Takes a whole village. I think palliative care in itself is truly a specialty. Like, there are certain things that you have to take care of, the patient's comforts. It's not just pain. I think people talk about pain, but there are things which are uncomfortable, what they can eat, difficulties with eating and moving around. What are the expectations, like, which I think for a patient, expectation is actually very important, right? Even our own loved ones. I mean, when my own father-in-law was unwell, I mean, honestly, everybody asked me, "So what happens next?" I'm like, I really actually don't know. Especially for a particular disease process, we don't know. You see, but the palliative care people were actually very good. When they came, they could advise what to expect. And once you know what to expect, I think it is much easier, and also for the family is easier when you know what to expect and what might be coming. You don't feel so anxious and worried, and then you're like, every other day you're going, "Oh no, why is it like that? No, is this what's happening, or whatever it is, so I do think that is a really quite a major role for palliative care. Like, it's just that I guess for young people who want to go into it's not one of those very glamorous, high-end specialties, and the conversations and the emotional burden, I guess, is high as well. Yeah, so I think that's where it is for palliative care at this point in time. One of the things which I think patients get very worried about, like I talked about, this sense of abandonment from, let's say, their own primary physician, is that once I engage palliative care, it's a one-way street. Right? Everybody sort of says, "Oh, this patient's on Palmet," right? And then everybody withdraws. People won't, treat you like a patient. They will treat you like, okay, it's a palliative patient, end of life, and so you might not get the best care. It's meant to help you in that journey, to help the family and the patient understand what is in that part of the journey. But it's not a one-way street. I think that should be really made clear to patients. We are starting to teach some of these what I call soft topics. In the past, it it would barely, get to the curriculum. The soft topics around communication, ethics, respect, life, death. It's very difficult to teach value. You inculcate value. That comes from when you are much younger, right? When you know what your family thinks and how school has taught you in terms of value, how you value life in general. Social norms still have it that some people prefer not to talk about, death, and not to admit that, perhaps it is the end of the road and you still want everything from intensive care to everything else. But that sometimes is because you and your family have never talked about it. You have not had time to come to acceptance. You have, I mean, it's like a surprise. Oh my goodness, you mean he's really so sick, and then it's the first time that this topic is broached, you see. If there have been more conversations, I think it is actually easier. And similarly for the younger people, I think sometimes they don't feel that they are the ones who can start the conversation. So even in difficult conversations, I think we try and make sure we tell our younger doctors, anytime that you feel that it becomes a difficult conversation, maybe you should bring a more senior person in, right? And it's not because the more senior person is more clever, knows more facts. When I'm younger and I'm less sure of the boundaries or how far we can go on this, you are less likely to, I'm more likely to say, look, this is my opinion, we can do this, right? And be less able to listen to the other party. It's just a journey of maturing, I think. In fact, I would be more concerned if my young doctors are already, oh, okay, so you think cannot, huh? Okay, cannot. Lor." I think I'll be a bit more concerned if it swings to the other extreme. Pushing the boundaries for success and for curative, I think is still a good thing, right? And talking about, the chances that it's not successful is just a necessary thing. And it comes with more conversations and more connections.